Hi there, everyone. My name is Jim Hefner. I am one of the founders of the Student Physical Therapist, and currently I practice in Boulder, Colorado in a cash-based physical therapy clinic. In today's lecture, we're going to go over the cervical spine, specifically covering the anatomy and biomechanics. So with that, some objectives are going to be to gain a more thorough understanding of the anatomy and biomechanics of the cervical spine. That is going to help us with our differential diagnosis in later lectures. It's going to help us with our treatment, our palpation. Understanding where the anatomy is going to be key for some of those things later down the line. And you'll see that we talk a lot about pathoanatomy. Our pathokinesiology, we kind of go away from the pathoanatomy or the anatomical structures as the source of pain. But regardless, it's important to understand where the anatomy is so that you can better direct your treatment. Also, we're going to identify bony and soft tissue anatomy and understand the anatomical significance of each structure. One thing that we'll talk about really in detail is the vertebral artery and the path of the vertebral artery, because it's important to understand when you're performing that test, even though it doesn't have the best sensitivity or specificity, to know where it runs and why certain positions can place extra stress on it. Also, understand the biomechanics of the upper cervical versus lower cervical spine. The C0 to C2 region is much different in how it moves versus the C3 to C7. And then also describe the path of the vertebral artery and reasons why VBI or vertebral basilar insufficiency may occur. So we're really going to hit on that quite a bit. A quick quiz here. Some of the stuff you may know already, some of it you may not know, but this is really what we're going to be getting into today. So first one, what structure is directly posterior to the dens? Now that is going to be the transverse ligament. And the reason it is important that the transverse ligament is just posterior to the dens, because that is going to prevent any translation of the dens into the spinal cord, creating any sort of upper cervical instability or creating a spinal cord injury. Question number two, the uncinate processes primarily limit what motion? Uncinate processes are in the cervical spine, as we'll talk about. They limit side bending. So I've worked with a lot of older people that come in with limited side bending motion. And the reason their side bending is limited is because of those uncinate processes are prone to osteophytes. Next, what motion primarily occurs at C1, C2? This is going back a little bit for certain people, but in the C1, C2 region, rotation is the primary movement. What is the closed pack position of the cervical spine? That is going to be full extension. So full extension, if you would go reach your head all the way back, you can sense there's not a lot of movement. The open pack or mid pack position is just in midline. Closed pack, where there's not a lot of movement, things are really approximating, is going to be full extension. And question number 5, the final question. What structure does the vertebral artery pierce through after it emerges from the C1 transverse process? And that is going to be the posterior OA membrane. And that's important because really it's more for regional anatomy purposes. It's important to know that the vertebral artery passes through the posterior OA membrane. It's right by the C1 nerve. It's just in front of the occipital triangle. So understanding that association is going to be really important. So a little bit of overview of the cervical spine. There are 7 cervical vertebrae, as you can see in the picture. An even more general overview of that is the cervical vertebrae are really meant to protect the spinal cord. So if we didn't have this strong pillar, the articular pillar or the vertebral column protecting our nerves, then they'd be vulnerable for injury, and it really wouldn't allow us to perform the movements that we need with our extremities. It allows for a mobile head. So without having the proper mobility of the cervical spine, let's say someone's limited in their upper cervical mobility, then they're not going to be able to, let's say, to look over their shoulder when they're driving, or really any time that you need to do a quick sort of movement, you won't have that mobility if something is restricted in the C-spine. It's also closely integrated with our sensory and vestibular systems. As you know, in the upper cervical spine, there's multiple nuclei that go up into the TMJ region, that go up into the ear canal. It is directly related with how we move and our sense of perception in relation to space. I was taking a parkour training class, so kind of like a free running where you have to do all this jumping and rolling and things like that. And in the class, there was someone who was a high level triathlete. He'd done more like seven or eight Ironmans. And so all of his movements were just front and back. He was swim, bike, and run. Everything was in the sagittal plane of motion. And really what happened with him is that he lacked the ability to integrate his vestibular system in a different movement. So he had trouble with rolling type movements, and he was getting really dizzy when he would have to jump and then do a rolling motion. And that's key because it's not that he had something significantly wrong with him, but because his cervical spine mobility was really limited, he therefore wasn't tapping into his vestibular system, and that's causing multiple issues. And also, as an overview, the origin of the entire peripheral nervous system, as well as primary circulatory structures, pass through this region. So the carotid arteries, the vertebral artery, jugular veins, everything is going to be passing through this region. So we need to make sure that it's well protected. Next, when we look at incidence and prevalence, this kind of shows how much cervical spine disability and pathology occurs across our society. So roughly about 22 to 70%, so a huge number of people are going to have neck pain at some point during their lives. That shows that it's just really across the board whether or not you will get neck pain. About 10 to 20% of the population report neck problems at any given time, and then that percentage increases with age. Now that doesn't mean that you're going to have neck pain as you get older. So age is not a risk factor for neck pain, but more so it goes back to a lack of movement or a lack of mobility as someone gets older, and that's going to increase their risk of having neck pain. Next, about 30% of patients with neck pain will develop chronic symptoms. So that's pretty significant. So if you have an episode of neck pain, there's a pretty good chance, or a 1 in 3 chance, that you're going to develop some sort of chronicity to your symptoms. 5% of people with neck pain are going to be disabled by their pain, which means they will no longer be able to work or be able to function with their normal daily activities because of neck pain. 42% are going to miss more than 1 week, and then 26% are going to have a recurrence of their neck pain within the first year. That tells me that we're not doing a good enough job once someone has an episode of neck pain, keeping their neck pain down and also giving them the proper education to say, hey, this is how you avoid it from coming back. That's our job. Something that we'll talk about, especially in later lectures, is this concept of pathoanatomy versus pathokinesiology. Pathoanatomy means that the anatomical structure is what is causing the pathology. Pathokinesiology is more of the poor movement pattern, or the kinesiology is what's causing the pathology, so a movement-based problem. We talk a lot about more of the movement-based problems as causing the issues, and that's really because of our deeper understanding of pain science these days. But with that, you'll see that as we go through this stuff, clear diagnostic criteria have really not been established for these various conditions. So we know that if someone has cervical radiculopathy, they're going to have decreased rotation, and they're going to have a positive swirling, positive distraction test. And we're ahead of a lot of different fields, in that we actually have research that helps back that sort of stuff up. But overall, with the majority of our problems, if someone comes in with just mechanical neck pain, there's not really clearly defined diagnostic criteria of how we should treat those people. And that's where the pathokinesiology is really important. Because the question really is whenever you work with someone, how much does that anatomical structure really matter? If there's a big red flag issue, let's say there's a serious pathology, then the anatomical structure might be more important. If it's just mechanical neck pain, probably desensitizing whatever the painful stimulus is going to be the real issue that we need to get down to. So when we're reviewing this stuff, the way I look at it is this person appropriate for treatment? Do we need to treat and refer, or can we just treat them in physical therapy? We're going to go over this topic of pathoanatomy or pathokinesiology quite a bit. So getting into the anatomy, as you can see here, we have the ligamentum nuchae, and that is going to be on the left side of the picture there. And that's important because it resists a big flexion movements, a lot of muscles attached there, so the upper trap attaches onto the ligamentum nuchae, but it helps provide some posterior cervical stability. Also, you can see here is that there is 7 vertebrae in the cervical spine. You can see the vertebral artery passing through as it goes to the transverse foramen. You can see that this is T1 because there is the demifacet, so where the rib is going to come off of there. So the first rib comes off of T1 right here. Then also you can gradually see how the spinous processes get larger and larger as they transition from cervical vertebrae into thoracic vertebrae. And so this is going to be C7, our vertebrae prominens, which is the most prominent vertebrae. And that's important clinically because we have that extension test where you can have someone just slightly extend their neck. C7, because it's so prominent, will remain there, and C6 will disappear into extension. Okay, and the next picture here, this is an anterior view of what you see in the cervical spine. So you can see at the very bottom center here, the anterior longitudinal ligament, and that is then going to turn into the anterior AO membrane. So you have your anterior longitudinal ligament, which resists extension of the cervical spine or extension of the spine in general. That is then in the upper cervical spine, turning into the anterior AO membrane. This provides anterior and posterior translation, but the anterior AO membrane, along with the posterior OA membrane, AO membrane, which we'll show in a second, are also important for vertical translation. So understanding those differences, but just know that the anterior longitudinal ligament is going to turn into the anterior OA membrane as it goes up into the upper cervical spine. Also, the reason that we don't talk about the anterior AO membrane quite as much is that it is much more, that structure as it turns into the ALL, anterior longitudinal ligament, is much more prominent in the thoracic and lumbar spine. So it's just well researched and less well studied in the cervical spine. This is a good, if we look at the picture on the left, we can see a side view of what we were just looking at. So all the way on the left is the anterior longitudinal ligament, and that's going up into the anterior AO membrane, as you can see in the very top wording on the left picture. And then what we have next is going to be this posterior longitudinal ligament. And then deep to the posterior longitudinal ligament, if you go over to the right side of the picture, is where you're going to see the cruciate ligament, the transverse ligament here, and you'll also see another view of the posterior longitudinal ligament. So that goes, if you have the anterior here, and then you have the body of the vertebrae, and then the posterior longitudinal ligament is on the back side of the body, but still in front of the spinal cord. So we're not even to the spinal cord, or we're not into the vertebral canal yet, because that is going to still be posterior. Another view of from the posterior side here, you can see the posterior AO membrane, and that's going to be a continuation of the posterior longitudinal ligament. So the posterior longitudinal ligament is going to resist spinal flexion, cervical flexion also, but then the posterior AO membrane is going to be that upper continuation of the posterior longitudinal ligament. The wording on this picture to the left, it says there's an arch for passage of the vertebral artery, as the quiz question suggested, and then also the first cervical nerve. And that's important because people that have, let's say are having cervicogenic headaches, we know that's highly related to decreased mobility in the upper cervical spine. So their C0 to C2 region is not moving properly. It's probably not allowing for normal nerve mobility in upper cervical spine, and that can lead to cervicogenic headaches. So the pattern of referral for the C1 nerve is going to be up into the posterior occiput and even referring around to the head, around behind the eyes, and that's very similar to the cervicogenic nerves. There's a more clear picture of the suboccipital nerve right here, and then you can also see the vertebral artery on my cursor as it wraps right around the posterior arch of C1 and then goes through the posterior AO membrane. All right, another quiz question was talking about the vertebral artery. So why is it important and where does it run? Well, it's important because it provides about 11% of the blood supply to our brain. So if that gets occluded, then it can cause things like dizziness, dysphagia, difficulty speaking, difficulty swallowing, those 5 Ds and 3 Ns. Well, that's why it's important, because it gets blood supply up to our brain. Now, where does it run? Well, first of all, it branches from the posterior and superior portion of the subclavian artery. So if you look down at the bottom of the picture, you can see in red, it says subclavian there. The red is the whole subclavian artery, and a branch of that is then going to be the vertebral artery. It enters typically the transverse foramen of C1 or C6. Now, so there is some variability there, and you'll see that in some people it's on C5 or C4 even. For the most part, it goes through C6 transverse foramen. It's going to pass up through all the transverse foramen, and it's going to exit the C1 transverse foramen and wrap around the posterior arch of C1. Now that's important because as it's wrapping around, that is going to be a major point of tension, or where it can get stretched, and some occlusion can occur when you're doing your VBI testing. Next, it's going to pierce the posterior OA membrane, going to travel through the foramen magnum up to the brain, and then it becomes the basilar artery, and it helps provides blood supply to the brain. Getting back into the bony anatomy here, we can talk about the 7 cervical vertebrae. There are a few unique or key features in the cervical spine. First of all, what you can see with the body is that the body is going to gradually get bigger and bigger as you go from C3 down to C7. Also, along the sides of the body are those uncinate processes here. So they're also called the joints of Luschka. But the uncinate processes, as you can imagine here, are going to limit side bending range of motion. Moving laterally to that, we have our transverse process. And between the body and the transverse process, you're going to have our transverse foramen. The transverse foramen are unique to the cervical spine. They house the vertebral artery. I don't really think they hold much function other than providing a stable place for the vertebral artery. A little bit more anatomical association, you can imagine that on the front of the body, so the very top of the picture is where the anterior longitudinal ligament would be. On the back side is the posterior longitudinal ligament. And then this big space here is for the spinal canal, spinal cord. Finally, we have bifid spinous processes in the cervical spine, which are gradually going to transition into just a single point spinous process as you get down into the thoracic and lumbar spines. From a side view, you can have a good vantage point of the facet joints. Now, when looking at this picture, where is this snapshot taken from? Is this cervical, thoracic, or lumbar? Well, based on several factors, I know that this is going to be a thoracic vertebrae. First of all, we can see the demifacets for rib heads, and we know the ribs are going to be in the thoracic spine. Also, you can see the sharp angulation of the facet joints. In the cervical spine, the facet joints are angulated more at 45 degrees in the frontal plane. So in this picture, you can see how they're much more upright. In the cervical spine, those things are going to be angled at about 45 degrees. So when you flex forward, they're going to go this way. Extend backwards, it's going to go that way. And then rotate, there's going to be variable amounts of movement of opening and closing too. What's very important about the facet joints is that they're highly innervated. They contain a lot of mechanoreceptors, and that is going to be our feedback loop back to the brain. So mechanoreceptors, they help with positional awareness, they help with pressure sensitivity. So they're going to be when someone's having a lot of pain, it could just be, let's say they have a crick in their neck. Well, likely for whatever reason, that facet joint could have been put on a prolonged stretch or is receiving too much compression, but how the mechanoreceptors are being stimulated has been altered, and we need to retrain that movement to restore normal strength and restore normal range of motion. In the cervical spine, the facet joints are going to face posterior and superior. The superior facet joint is going to face posterior and superior like this, and it's going to match the inferior facet, which is going to face anterior and inferior. So if you would look at a picture of a cervical facet, just know that how they face is really more in the posterior superior and anterior inferior directions. All right, I've briefly mentioned these uncinate processes before. They run from C2-3 down to C7-T1, so they're not through the entire cervical spine, but just through a portion of it. And that's important because if they were up at C1, C2, it would really restrict the rotational motion, and we don't want that to happen. So there's a reason why that they are in this region. Uncinate from the Latin means uncus, which is like a hook type structure, and that's why you'll see a hook on either side of the vertebral body. They're going to limit side bending, as we talked about. They really are guidelines for flexion and extension. So they help guide normal flexion and extension range of motion. What is important with them is that in the cervical spine, we really don't have a lot of posterior lateral disc herniations. If there is a disc herniation in the C-spine, it's going to be more directly posterior, and that's because they help block any posterior lateral herniation of the discs. Unfortunately, as people get older, these things they are more prone to degeneration. So just know that if someone comes in and say it's a 55-year-old male and he has limited cervical side bending, that could be because his uncinate processes or his joints of Luschka, the uncovertebral joints, they all have the same meaning. They could be restricting his movement. Looking at some soft tissue structures here, the blue arrow is pointing to our alar ligaments. And on a real live human, those things are about the thickness of, let's say, a pencil, for example. So if you take a standard number 2 pencil, they're fairly thick structures. They can resist about 240 newtons of force. Now that probably doesn't mean a lot to a lot of people, but in relation, the ACL can have about 600 to 800. So they're about a third of the strength of what the ACL can resist. But that's why we also have the transverse ligament here. We have the cruciate complex, which also helps provide that upper cervical stability. As you can see in the picture, they attach to the dorsolateral surface of the dens and they travel up to the occipital condyles. So they go from the back outer side of the dens. If this is the dens right in the middle, they're going to go here and they're going to travel up and out to either one of the condyles. Their function is to resist flexion, contralateral side bending, and rotation. So if you are stressing someone's left alar ligament, the left alar ligament is going to be resisting right lateral flexion or right rotation. So that's why when you do right rotation, you can imagine that the left alar ligament is what is getting stretched or pulled, resisting that movement. Along with the transverse ligament, it is one of the key stabilizing structures in the upper cervical spine, so it's very important. Personal clinical example here, I was recently working with a young woman who really had no significant past medical history, a car accident a long time ago, but she said, please be careful. When anyone distracts my neck, sometimes I get blurry vision and I lose eyesight in my right eye. I thought that was first of all, it's important because she's likely something is going on that's causing that. It could be potentially an upper cervical nerve of some sort, or it could also be decreased ligamentous support in the C-spine. I did an alar ligament stress test to both sides, and I found laxity on her right side, which is also the side that was causing the neurodistribution, the neuro deficit that was leading to the visual eye field loss. And I made sure that she's had this issue for a long time. She's living just fine without it. But I just said, hey, I'm not going to perform this for that reason. I just noticed this test. Have you experienced any other signs or symptoms that are associated with this? She hadn't been, but my treatment really was just to stay away from any sort of upper cervical mobility or any upper cervical manipulations. Next, what you can see here is the cruciate ligament or the cruciate ligament complex. So cruciate means cross, so that's why it's that cross-shaped structure right where the center of the blue arrow is at. This includes the transverse ligament. That's the biggest and most important ligament in the upper cervical spine. Its main functions here are going to be checking superior and inferior displacement of the transverse ligament. So this whole complex helps stabilize the dens and keep it in place to resist any translation into the spinal cord. Also, what's good is that here you can see peeled back is the posterior longitudinal ligament. So we're at a layer that's just in front of the PLL, or its superior continuation, which is the posterior OA membrane. A little bit better picture of this, we have our transverse ligament, and as I mentioned before, it holds that dens in place. So if this is the dens here, anterior, posterior, the transverse ligament is going to be back here, and the spinal cord is just behind that. So let's say someone has a quick whiplash accident, that is going to keep it from pushing posteriorly. Prevents anterior translation of C1. So posterior translation into the spinal cord are really the opposite as resisting the anterior translation. As you can see, it attaches to the lateral masses of the atlas. So you have your atlas, then your axis. And so this is really, it helps stabilize the dens. C1 is what it prevents, okay? It doesn't attach onto C2, down onto the axis. If injured, AA instability will exist. AA instability can present in a number of different ways. That could be any sort of fracture, that could be a spinal cord injury. The treatment for that is going to be different based on what the imaging shows, and also really we're not going to be treating them at this point. So sometimes they'll need surgery, other times they'll just need some sort of stabilization. But just know that this is out of our hands for a while, most likely if someone has a transverse ligament issue. Getting into a few muscles, and we won't cover this too in depth, but the ones that's shown in the picture, that's going to be our scalene muscles. So we have anterior, middle, and posterior scalenes. The scalenes, they have a function of either helping move the neck or they're going to help fix the ribs. Now, one issue with that is that they can, because the anterior middle scalenes attach onto the first rib, they can provide a superior directed pull on the ribs and cause some sort of rib dysfunction. In the picture here, you can see the posterior scalene goes also down to the second rib. So I had thoracic outlet syndrome personally, where they had to go in and remove my first rib, and the surgeon just chose to cut out my anterior middle scalene. So I lack those structures, and those are important. Yes, they help stabilize the rib, but they also help with cervical rotation. So my cervical rotation going to the right feels much more limited. It just feels like I'm missing some sort of that movement. So I'm lacking some anterior stability on that side. Other muscles that aren't highlighted in the picture, but you can see the longus colli, the longus capitis, the rectus capitis anterior and lateralis. These are going to be our deep cervical stabilizers, or our deep neck flexors. Those ones that run right along the spine, those are the muscles that are really going to help keep our neck long, prevent any sort of buckling or hinging that often eventually tends to lead to pain. And then finally, we have on the posterior side, which there's no picture of this here, but it's our suboccipital muscles. And these are really important for fine-tuning of positional changes. So everyone, place your hands on the back of your neck. And what I want you to do is look to the left and then look to the right. So just your eyes, don't move your whole head. And you'll actually feel small movement occurring in those suboccipital muscles. And that shows how directly related your upper cervical spine is to your vestibular system, to upper cervical, or to head and neck movement. Really important for people that have cervicogenic headaches. So let's say those muscles here, which are really important for kicking on and having positional changes. Well, if their muscles back here are getting fatigued or compressed, that can mess with their eyesight. It can mess with vestibular system. So very important clinically to make sure that the joints, those muscles are moving properly. Last slide here on anatomy and biomechanics is just some general information about the cervical spine. The resting position is going to be midway between flexion and extension. So just right here in this position, I have good mobility in all directions. If I go fully back into extension and try to rotate, I have less mobility because that's the closed pack position. So there is the least approximation of structures in that resting or open pack position. Closed pack is where there's approximation of structures, limited mobility. So that is full extension of the cervical spine. Finally, I don't see this clinically too much, but the capsular pattern of the cervical spine is side flexion and rotation are going to be equally limited, greater so than extension. So really with a capsular pattern, we don't see a flexion loss, but we see side bending and rotation, greater extension or greater loss than extension. Looking at the cervical arthrokinematics, what we're talking about here is how those facet joints are moving on one another. This can be thought of in two different things. So we're going to talk about it as right here on the next two slides. That's going to be the lower cervical spine, how we're going to talk about this. So from the C2-3 down to C6, C7. Upper cervical spine, the C0 to C2 region, is what we're going to cover next, and that doesn't apply to what we're talking about right here. As you can see in the pictures, with cervical flexion, I want everyone to flex their head all the way down towards their sternum now. You're going to have bilateral opening of the facet joints. So that the facet joints are going to be moving up and forward on each other. Now, if you extend all the way back, so extend your head all the way back, look up towards the ceiling, literally you can imagine bilateral facet closing where those facets are going down and back. It's the opposite movement of what's happening in flexion. And because it's happening on both sides, that is going to be an extension, which is different than our side bending and rotation. Understanding that's important for the side bending and rotation here. So as you can see in the picture, this is going to be cervical lateral flexion to the right. And so I want everyone to do that. As you laterally flex to the right, you're going to be closing down the right side and then opening up the left side of the cervical spine. That closing on the right side is essentially the same thing that you're doing with extension, that down and back movement. So in the picture on the left, the cervical flexion to the right, he's closing on the right and then opening on the left, essentially flexing on the left side and extending on the right side. The same thing is true for rotation. Again, if you rotate all the way to the right, look as far as you can, the right side is going to be relatively closing down. The left side is going to be opening up. A quick question example for everybody then. What's happening with left cervical side bending at the facet joint level? So what's that? Is the left side opening or closing? And is the right side opening or closing? So with left side bending, the left side is going to be closing down and the right side is going to be opening up. That's essentially extension on the left side, flexion or opening up on the right side. Now, this is a little bit different part here. The OA joint and the AA joint have completely different arthrokinematics. And we're going to get into that after a brief talk about the anatomy. First of all, the atlas has two ellipsoid concave joint surfaces that are going to face medial and superior. And that's going to accept the occiput. It's going to match where the occiput's facing. So you can imagine if this is my atlas, these are my big surfaces that are going to accept the occipital condyles. So because they're facing medial and superior, the occiput is going to be convex and it's going to face lateral and inferior. Now here we have a convex on concave surface, so we know arthrokinematically that it's going to move in opposite directions. The OA joint primarily allows for 2 degrees of movement. That's going to be flexion and extension being the primary ones. So that upper cervical nod is what occurs at the OA joint. But there's also a small amount of side bending, and we're going to look at that side bending component when we talk about the arthrokinematics. Rotation is negligible because we need that rotation to come from C1, C2. If we're having, there's just not movement, if you look at the bone-on-bone structure, for rotation to occur at the OA joint. The bottom picture here, that is more for a clinical standpoint. You should know that side to side, those transverse processes, when you're doing your palpation here and you're looking at how wide the C1 transverse process is, it's about 90 millimeters apart. A lot of times when people are first palpating, they're gonna, they move just lateral to the spinous process and think they're on the transverse process. Know that to find that, you're gonna be way out here, just inferior and anterior to the mastoid process. So those things are pretty wide, about 90 millimeters. When we talk about OA joint biomechanics, as I mentioned in the last slide, the flexion and extension are going to follow the normal arthrokinematics, almost similar to the C3 to C7. So with upper cervical flexion, everyone doing up just a chin nod or give yourself a double chin. That upper cervical flexion, the condyles are going to be gliding posterior on C1. So the head is moving posterior, it's going to roll anterior, glide posterior. The opposite occurs with extension. with extension, upper cervical extension, the condyles are going to be gliding anterior. So it's going to roll posterior, glide anterior, or relative, if you would look at that as a mobilization, you'd have to do an anterior mobilization at the OA joint, which I don't know why you rarely, I don't think I've ever seen anyone who needs an anterior mobilization. Too many people sit in upper cervical extension already. And so we need to promote more posterior gliding of the OA joint. The difference here, and this is a very important distinction, is that side bending is completely different than OA flexion and extension. And this only applies to the C0, C1 joint. This doesn't apply to C1, C2. It doesn't apply to the lower cervical spine, only at the OA joint here. With right cervical side bending, the right occiput is going to travel what we say the acronym MIA and LIP. So with right cervical side bending, it's going to travel MIA. So just a small upper cervical side bend to the right. The right side is going to go medial, inferior, and anterior. And then the left side is going to go lateral, posterior, and superior. If you're assessing side bend in the clinic and you go all the way over here, you're doing way more than upper cervical or OA side bend. It's just a small, 5 degrees. You can barely see that movement, but it's going to have this composite motion of, if it's right cervical, upper cervical side bending, it's going to go MIA on the right side and then lips on the left side. Opposite occurs the other way. If it's left cervical side bending, it's going to go MIA on the left side, medial, inferior, and anterior, and then lateral, posterior, superior on your right side. So for OA side bending, remember the acronym, MIA has nice lips. And then finally, the AA joint, or the atlantoaxial joint, which is C1, C2, is our joint for rotation. So all of that movement is going to be happening around the dens, and this joint is set up for rotation. If we just talk about the bony anatomy, the inferior surfaces of C1 are biconvex. So if you have the big condyles here, the inferior ones are also convex. And it's going to match up on C2 to a biconvex surface also. But fortunately, that in that region, we have cartilage buildup on both the inferior part of C1 and the other part of C2 where it meets it. And those actually turn into a concave on concave situation. Doesn't matter too much because rotation, or that rotary movement, is what's really important in this region. But just know that the bony structures are going to be different than what the cartilage actually looks like, changing the anatomical orientation. There is 2 degrees of freedom here. We have transverse plane movement, which is going to be our primary one, so into rotation, and we also have some sagittal plane movement, just a very small amount. That is a pretty quick and dirty overview of the cervical spine anatomy and biomechanics. If you have other questions on upper cervical mobility or how to check for upper cervical motion, specifically the arthrokinematics, please check out the bonus links below where Chris has an article that looks at how the C0 to C2 region moves in relation to the C3 to C7 region. Please reach out if you have any other questions, and we'll see you in further lectures.